I have the pleasure of introducing our speakers today. We have three speakers today. Kayla Strother, APRN, serves as a nurse practitioner with the Addiction Consult and Education Service at the University of Kentucky Chandler Medical Center. She has experience working as a registered nurse in the Trauma Intensive Care Unit at UKMC and as a clinical nurse instructor with Morehead State University Bachelorette of Nursing program. She has a strong interest in staff education and development with a concentration on the care of patients with substance use disorders, and is an active participant in community outreach programs that work to educate the public on substance use disorders and Narcan administration. Alyssa Tremblay is currently the clinical social worker for the Addiction Consult and Education Service ACEs at UK Chandler. She received her undergraduate and master's degrees in social work from the University of Kentucky. Her areas of expertise include work with patients with concurrent substance use and infectious disease, as well as brief mental health intervention, mindfulness, and DBT-based strategies. She has been working in the areas of substance use, mental health, harm reduction, and health advocacy since 2012. And Angela Linder is currently the nurse navigator for the Addiction Consult and Education Service at UK Chandler. She received her Bachelor's of Science in Nursing from Berea College. She is a certified psychiatric mental health nurse with the American Nursing Credentialing Center. She has 20 years of experience working in acute inpatient mental health. So welcome to our speakers.
Thank you so much for having us. Are we going to go ahead and start or give a few more minutes?
We are all set to start.
All right, so we have no financial disclosures. So we're going to be talking about practice gaps and educational needs in the areas of harm reduction, practices that reduce illness and injury. And then we're going to start by speaking about kind of the basic principles of harm reduction, and then we're going to transition to kind of how to prepare for those conversations, how to come into those conversations, and then the content that we use when we do harm reduction teaching, and the kind of strategies that we use in the work in this field. So our specific learning objectives are going to be to discuss the history and philosophy of harm reduction, to articulate the benefits and challenges of doing harm reduction, and kind of preventative medicine in formal healthcare settings, and then how to employ those specific harm reduction interventions by different routes of administration and with different substances that you may encounter. Our expected outcome is that folks will improve their understanding of opportunities for harm reduction education among people who use drugs, and to utilize client-centered, empowering, collaborative approaches to creating harm reduction plans with people who use drugs of any kind in any setting. So we want to start off by just kind of creating a framework for why we do this work, why harm reduction is important to us, and why we think it's a pertinent thing to discuss in the climate that we have now. When we talk about, substance use disorder treatment and access in Kentucky, it's not something that people are usually surprised by when they live in this area. When we look at the number of overdose deaths among Kentucky residents, they have steadily increased, especially during the recent 2 years that we have had. The annual OD, the national average for annual ODs, overdoses is up 37% from 2021 to 2022. In Kentucky specifically, we followed that trend. It is up by 14% from 2020 to 2021 as well. So we're seeing an increase in overdoses. When we look at our major sources of research and education with the Office of Drug Control and Policy, the statistics are that 9 in 10 Kentuckians suffering from substance misuse go untreated. We have some of the highest rates in the country of women who are pregnant and also using opioids. We have one of the highest rates of Hep C infection. We have very high rates of endocarditis related to injection drug use. So it kind of, I think, is some evidence to why this practice is important in healthcare. And when people kind of ask you why you want to include it in your practice, these are very easy things that kind of spring to mind. This is kind of more evidence to support what we're talking about when we look at the research that's being done on vulnerable counties for at-risk HIV outbreaks. Of the top 220 vulnerable counties in 26 states, this map kind of shows us Appalachia is hit very, very hard by this, and the majority of these counties are currently located in Kentucky. So we're going to start with kind of the basics of what is harm reduction. When we said we were going to come and do this talk, we had a bunch of people ask us, so what does that mean though? What is harm reduction? So harm reduction, there are a few ways to think about it. It's an organized series of strategies designed to reduce the harmful effects of alcohol and other drug use on individuals, their families, and with society at large. I like this one in particular for what is harm reduction. It's a continuum of possibilities of behavior modifications. Those benchmarks are always changing, but the continuum always exists. It's an evidence-based reduction of morbidity and mortality, and it is really any measure that reduces the harms associated with drug use, whether a person stops using or not. And I think the Harm Reduction Coalition speaks about this often, but harm reduction does not in any way seek to minimize or ignore the real and tragic harm of dangers that can be associated with illicit drug use. It is about empowering people to take control of their own risk and to manage that in ways that they feel comfortable. So a really great thing about harm reduction, we're going to talk about it today, and you're going to come out, hopefully feeling more confident than you did before. But a really great thing about harm reduction is that you already see it. You see it in your everyday life. So I'm going to go ahead and ask you, and this doesn't have to be related to drug use in any way, but just harm reduction in general. Do you have any examples of ways that you already see this done in your life? Behavior modifications, strategies, things in your everyday home, even. Helmets, absolutely. Seatbelts, huge. Condoms, absolutely. Naloxone, yes. Sunscreen is absolutely harm reduction. Lifeguards, yes, absolutely. Yeah, so these are fantastic. We'll flip to the next slide and we'll cover just a few more. You guys got a bunch of them. So seatbelts, sunscreen, speed limits. We don't stop driving the car just because there have been accidents, but we do try to set some expectations for speed. Traffic lights, birth control pills, cigarette filters. We know cigarettes are dangerous. In the state of Kentucky, we certainly know cigarettes are dangerous. We don't have everybody stop smoking. Obviously, the safest way to smoke would be to not smoke at all, but then we make it a little safer by adding a filter. When we look specifically at substance use disorders, we're talking about syringe service programs, safer injection education, overdose prevention, naloxone, like somebody already mentioned, dose management, emergency response, and training of emergency response, EMTs, to take care of overdoses in folks with substance use disorders, supervised use sites, drug testing, and the nicotine replacement. We're going to talk about some more of those a little bit down the way, but that's just kind of to make sure everybody is aware. Harm reduction doesn't have to be a thing that is like separate from everything else you do in your life. It doesn't have to be a scary concept. And then when we understand what harm reduction is, why do we do it? What is the point? Because it's not an easy thing to do. So what's the motivation? For one thing, it increases our understanding. When you come at your practice in whatever site that you may be practicing in, we're talking about challenging stigma with harm reduction education, and from practicing with a philosophy that focuses on harm reduction first. We improve communication with the people that we work with, and we create an opportunity for trust with those people. We see this all the time. When you engage from a place of harm reduction, you see greater engagement. It is empowering, it's motivating, it's uplifting. It gets people who might not have been willing to work with you before, who have felt marginalized, to engage with you because they feel respected and seen. And then we have the opportunity to see real, tangible change. We see immediate benefits to the individual and to the community when we practice from a place of harm reduction. And we're going to talk more specifically about healthcare in a minute, but this is just in general harm reduction. And then just to kind of give a frame of reference when we're talking about harm reduction, again, there are different ways in your mind to think about being a person. You may not be in the position to teach safer injection at your site, but you may be an administrator who is in a position to advocate for policies that align better with harm reduction. So when we look at kind of the three levels of harm reduction that are opportunities for you, we see, harm reduction as a philosophy and as a part of your politics. And this is with a focus on shifting resources from folks who have fewer of them, and putting resources into the hands of the most vulnerable. So opportunities to do that include advocating for better policy, voting in some states when things come onto your ballot, paying attention to your legal landscape, attending to policies which may contribute to discrimination, advocating for insurance access, and then in general access to treatment, or making pathways that are easier for treatment. That's like your philosophy, just the belief in the idea of harm reduction. And then we kind of have like little h harm reduction, which is your actual approach and your fundamental belief. So if you're a physician, kind of keeping in your mind that you're practicing with the background in harm reduction, that's a motivation, a goal for your interaction with a patient. And then kind of what you offer in your office, what you allow to be posted in your office. We have signs on some of our bathroom doors around here. I think that's a way we can kind of do harm reduction with a little h. And then we see kind of the actual practice of harm reduction being the strategies for reduction of risk. So these are services that we provide. That's syringe exchange programs and access to condoms in your workplaces. So you have many opportunities. It's not always going to be something like safer injection education. And then as far as the history, some of the questions that we get sometimes when we talk about harm reduction are, is it okay that I even talk about some of this, which is a perfectly legitimate question. I think it feels a little scary sometimes, like it's not okay to talk about harm reduction as a practice or as a policy. But when we look at the historical basis, just kind of make everybody feel better. It made me feel better. It made me feel like I was part of a community when someone pointed it out to me. We largely in harm reduction circles, we look back to this fella over here on the far left. His name is Dave Purchase. He was a biker in Tacoma, Washington, and he's kind of revered, I guess, as the father of what we now call harm reduction. Because during the AIDS epidemic in 1988, he kind of pioneered his own like table and chairs syringe exchange in an area because he was losing a lot of his friends. And from the work that he did, we saw a syringe exchange that was developed in Tacoma. I think it was in 1990. The Harm Reduction International was also established in 1990. The Harm Reduction Coalition that we still have now was in 1993. We see harm reduction now in the public consciousness. We have in the state of Oregon, we have some decriminalized use sites and a lot of really interesting referendums for harm reduction as a city policy. We have 2 supervised consumption sites in the United States now, with On Point in New York City, which was established in 2021 and has some really, really great research coming out. And now we have 82 syringe exchange services in 62 counties in Kentucky. So when we think about harm reduction, if you think you're the only person doing it and it's not going to be okay, there's huge precedent to do it, great research to support it, and you're part of this community. This is just more research kind of associated with what we were talking about before on projected savings and evidence behind harm reduction. The supervised consumption sites in New York, when they did a study of that, there was a projected healthcare savings of up to $1.6 million. And then for this is the projected effects, basically, of giving access to folks to syringe exchanges and increased testing in New York as well. And this is also just kind of a little bit of a making folks feel a little bit more comfortable. Legal landscape in Kentucky. This differs by state. But in Kentucky, there are laws explicitly permitting syringe exchange and all the activities that happen in a syringe exchange, which are a lot of what we're going to be talking about. There are some states that don't have any law at all, so you can kind of not really be concerned about it. And then there are some that would require legislation for syringe exchange. So paying attention to where you are matters, but specifically in the state of Kentucky, we have some protections. All right, and now we're going to transition just a little bit and talk very specifically about healthcare and why we do it in healthcare and what that looks like. So again, what we stand to gain. So when we're working in a healthcare environment, when we increase our understanding, when we create an environment where folks will talk to us a little bit more and see us as a collaborative partner in their care, we get more information. And the more information we have, the better treatment we can give, the more resources we can offer. Information is good. We can advocate better when we have a better understanding of what people need, and we can repair trust, because the healthcare system, historically, folks who have substance use disorders have been marginalized and stigmatized to the point where many don't want to engage with healthcare systems and the supports that exist within them. When we look at greater engagement, again, we were looking at increased likelihood for people to come to their follow-ups. Hep C treatment is a very long process. It's not a one and done. So we need folks to be able to come back to the hospital for 6 months at a time and stay engaged with their healthcare professionals. When we have greater engagement and more information, we have fewer complications. We have patients who are willing to do a little bit more self-advocacy to ask for what they actually want. And then we see real change, and we see this in real time. Patients reporting to us, when they come into the hospital that, I haven't injected in 3 months, or I haven't gotten an abscess in 3 months, and just being really proud of that. We see peer-led education within communities. I think this movement is growing just tremendously in 2022. This idea that folks in various levels of recovery are helping other people in various levels of recovery. And then we see policy change. The more we engage, because hospitals are very visible. We're not talking about, very, very small nonprofits that people who aren't in this field haven't heard of. We're talking about big hospital systems, and there's power there. So when you think in healthcare, and another reason why, if you ever experience pushback or kind of doubt in the justification for doing this, when you engage with harm reduction, you have an opportunity to meet people at every stage of change, whether they're still thinking, weighing kind of the cost benefits, seeing if even stopping using drugs is an option to them, or seeing if changing their practices is an option to them, if they're thinking about it, if they're not thinking about it, if they're preparing, if they're in action phase. There are options for them in the field of harm reduction. When we look at going from a place of abstinence only, treatment focused only services, then we can only catch people in this very last piece of this process. And we know that people fluctuate. This is not always a linear process. Sometimes you get to action and then you drop back and you change your mind. So this is about access to people, no matter the stage. So specifically in healthcare, these are things that we pay very close attention to before we start having these conversations for harm reduction. And I think when I see these, one of the things that it teaches me is before I come into a conversation, I'm preparing to come up against some of these things. And I prefer to do the work to figure out how to navigate some of these challenges before I'm in them. So I think these are great things to consider. Power dynamics are there. They're there all the time, but they're especially there in healthcare. Someone who is in crisis and doesn't feel very good, who's not really able to advocate for themselves, then has a person in a white coat, or a person who they perceive to be, more educated than them or more experienced than them. And none of these things may be true, but that's the feeling that happens when you're not feeling good and you're engaging with someone in healthcare. So being aware of your power dynamics and using strategies to mitigate those. So we don't usually talk to people standing up. That's the easiest way you can look at power dynamics, in a very physical way. We sit down with them, we get on their level, we use the same language that they would use, and we just let them know that we're going to be partners. I'm not going to tell you what to do. Another challenge is kind of the hostility, stigma, judgment. These are challenges that can come from the person that you're attempting to work with. These can also be things that you encounter in your workplace. Healthcare is an amazing system. We do incredible things, but we are huge and extremely diverse, and you're not always going to be around people that agree with what you're doing, or that are even openly kind to the people that you're trying to work with. So strategies for overcoming hostility, stigma, and judgment, that can be things like this, like trying to offer education. I think that can be simply correcting language. If someone around you is talking about, oh yeah, you're that person who works with addicts, right? That's a really easy opportunity to say, yeah, so I'm the social worker with the Addiction Consult Service. We support people with substance use disorders. And that's a really nice way. You don't have to say, it's a really ugly word that you just use. You probably shouldn't do that. It's kind of confrontational, but something easy like that in your professional and your personal life. And then we talk about coercion versus choice. We're going to talk about this a few different times today, but it's kind of this really huge idea that when you're talking to folks at varying stages of recovery in the field of harm reduction, you never want to be feeling like you're coming at something from a place of telling them what to do. And you certainly don't want to be coming at them with your own personal goal. So my secret goal in this interaction is to get you to stop using drugs. If you come in it like that every time, you're gonna lose. You're gonna have really terrible outcomes. So we're not in harm reduction to coerce anyone to change anything. We're here to give people options and let them choose. So again, with this idea of like groundwork that you lay before you even talk to anybody is to assume you don't know. Where do you get started? You can ask your patients, like, listen, I want to be better at supporting you in these ways. Ask them what would be interesting to them. What do people talk about? If are there any trends in the communities that are using the thing that you're trying to assist with at this time? Talking to other people with experience, attending educational events. There are a lot more of them now than there used to be. Touring syringe exchanges. I know they let professionals go all the time and just kind of see what it looks like during the day. Looking at the evidence that exists, because there's such a growing body of it. And Kentucky has multiple websites. If you look at the core links or the Office for Drug Policy, there are great resources there that you can search by a keyword. And then when we look at seeking out additional education, this is about improving your competency and your confidence. Because when you go into these conversations, if you're kind of bumbling all over yourself and you feel like you don't know what you're talking about, they're going to know. They're going to know. So build your confidence. There's a link on the next one about some other resources about where to get started if you're not sure. Obviously, Kentucky Open, I think, is a great resource, as are these. The National Harm Reduction Coalition has a fantastic website. We use it all the time, and they do update it pretty often. So if you're looking for things that are like geographically specific, that's a great place. Next Distro is also a fantastic resource. They also update fairly often. Those do depend on what state you're in, on what your options are through them, but they have great accessible information. We use the Getting Off Right text kind of on here on the right, and we have another slide that'll give you a QR code in a moment. That's a fantastic book. If you are not a person with any experience within injecting substances, it's just a great place to start. It has very approachable language. It has, I think it's not very long. It's a little bit older. I think it could probably stand to be updated just a little bit, but it's a really good option. And I think that QR code is on the next slide. So when these get published, you can kind of give that a scan if you would like to. You can also order them. They're not very expensive. All right. So we've talked about what your justification for doing it, why you're even going to try to engage with this kind of thing. We talked about what the basic principles are. You've built your confidence, and now you're going to actually have a conversation with one of your clients or one of your patients, a harm reduction education, a harm reduction approach, whatever you want to call it. So I think the way you say things probably matters in this context just as much as what you say. So we're going to give you the Cliff Notes of what we have found to be helpful to us. The first one is to check your bias before you walk in the door. These are sneaky. These are very sneaky. And when you work in the field of substance use and substance use treatment, you see things so often. I think some of that stuff stays with us. So if you walk into an interaction with someone, you say, oh man, this guy has the exact same history as my brother. He's going to try to manipulate me just like my brother. And you don't mean it in a mean way. You just go in there with that in your mind. But that's a bias that you're taking in with you, non-intentionally. Or you've worked with so many folks, you kind of think, I know what he's going to say. He's not going to want to do this. He's not going to want to do that. The temptation to make assumptions is another way to kind of notice that you have some biases creeping in. So sometimes even for us, before we walk into the door of a room where we're going to talk to a patient, we just kind of take a minute to level set. You know what? Every interaction with a person is an opportunity. We say this here all the time. So this is just another opportunity. I'm going to give the options, and I don't have a dog in this fight. I'm just going to say, here are some things. Would you like some things? And then see what happens. But that's an active process, and it never really stops. You can do this work for many years and still do it every time. Knowing what your goals are before you get into an engagement, I think helps also so much. Establishing mutual goals, I think, is the most important part of this. So again, if your goal is, I'm going to try to get this person to stop using drugs, you're going to lose every time. You can try it, but that's not a mutual goal. That's a you on them kind of a goal. So this can be a mutual goal of just, you should ask them what their goal actually is. And if their goal is that they're not sure, then you can say, well, my goal is to make sure you know as many possible resources on any level of the spectrum, so you get to decide that later. But I have information I'd like to share. You are going to receive information, and we'll just go from there. Looking for opportunities to reduce harm. So sometimes the goal of my engagement is just to figure out what's going on with this person. And what are the ways, as a person with a lot of resources in their mind, how can I insert them into our conversation? Meeting a client where they are. This is about the kind of a restatement of what we just said, kind of eliminating the should. If they're ready to do XYZ, we're going to go down that road. If they're not ready, we're going to pursue a different goal. And asking really good questions, I think, is important. I have not had it that people have been offended when I've asked pretty specific, direct questions. I've had it more often that people say, wow, no one's ever asked me that before. Yeah, I'll tell you. So if you don't know what their current use practices are, don't assume you do. So just ask, when was the last time you used this? Have you ever, injected? Where do you inject? These very specific questions from a genuine place of trying to gain understanding, they're usually received very surprisingly well. And do you know what their plan is? We ask a lot of times every day. Do you plan to continue? Do you think you might use when you leave the hospital? Because that's one set of information we can do, or if you think that you're less likely to, or we could talk about both. And then striving for advocacy from a place of neutrality. We talk about this all the time, and that's just kind of, again, a restating of this. I don't have a personal secret goal that I'm trying to achieve, which is to get you to stop using drugs ever. I am neutral. I am just here. I have some things. You tell me what you need. We interact as equals. So when we talk about harm reduction in the hospital, this is kind of the phrasing that we use when we know someone's maybe about to discharge and we want to do a little direct harm reduction. One of the things we try to talk about before people leave is something that we call harm reduction education, which is basically just, talking about how to keep you as safe as possible when you leave. For example, if you think you might continue injection use, we could talk about how to do that as safely as possible to avoid future infections like the one you had while you were here. We can also give you some community supports that are available, some other strategies, things for yourself or stuff you could teach your family. Would it be okay with you to go over some of this stuff? That's it. Opportunity for yes or no. How do you think I can best support you is a thing that we say all the time. It's a way for us to remind ourselves to stay neutral. And then ask more questions, make fewer statements. This is true for so many things. But can you help me understand? We say that all the time. Can you help me understand what your injection process has been versus, listen, you're here with Hep C and endocarditis. I know you've not been using clean needles. That's not going to be an opportunity for engagement. The latter is going to. And then you should only be ever using with sterile water, ever. Versus, there's kind of a hierarchy of water as we understand it. And, can we talk about what sources of water might be available to you? Can we maybe try an open bottle water versus the tap that you've been using? And then when you're having these conversations, one of the ways that we kind of help ourselves to kind of take some notes in the back of our minds without having to repeat a lot of things is to I keep this little graphic kind of in the back of our heads. So what are the risks as they're talking to you? If they're, letting you know that they do engage in sex work and they do inject drugs pretty much every day and they're homeless, that helps me so much. You just told me a whole family of risks that we can now attend to. And I didn't have to say, what are the risks you think that you have? I know, because you just told me. When we talk about the set, we're talking about like the mindset or the set of circumstances that people bring into this. If someone is mentioning that they have pretty chronic depression or chronic anxiety, that's something they're bringing into the set. If they're saying, they've done residential treatment like 15 times at the same place, and it's just never really worked for them, that's a set of kind of bias or kind of experience that they're bringing in that I can maybe think, ooh, I'm going to suggest something on the other side of the state or a different kind of recovery to them. If they're giving you like a set of family, like information about their family members who have also had interactions with recovery. And then what the setting is, the actual physical environment, whether you're like who's actually around them when they're using, how like the more physical environment of what's happening. So if you kind of look for some of these clues in the conversations that you have, it's going to set you up for much more productive harm reduction conversations in the future. And then, this idea of how you say it being as important as what you say, but what you say is hard. That's probably also the second most common question that we get is, but how do you actually phrase stuff when you're talking to people? Because I think people are very afraid to say the wrong thing or to come from the best intention, but not get across what they're trying to say. So these are just some examples of phrases that we find ourselves saying a lot. One of them is, I know you told me you're concerned about getting endocarditis again. So let me tell you this, we could talk about some strategies for safer injection, or maybe just some simple like safer use strategies to help you manage your risk. Which of those do you think would be helpful to you? Because then the patient doesn't have to be able to ask a specific question. It's kind of a motivational interviewing technique that we're talking about here. Instead of what do you need? Saying I have this and I have this. You tell me which one or both, and we'll do either one. It sounds like you're already doing a lot of things to keep yourself safe. Do you think we could talk about maybe just one more thing to add? This is for someone who tells you like, oh, I already know how to do everything. Maybe they do, but we still try. I understand, you don't think this is really helpful to you right now. Do you know of anyone who might benefit from some of this information? Like maybe you could teach it. I know you mentioned your brother earlier. This kind of sneaky way of like, it's not for me, it's for my friend. It is very, very common to have these conversations as well. And then, can you help me understand? We talked about this earlier. Can you help me understand like what your goals are? What are you going to do when you go home? What's your tomorrow going to look like? Is there any way that we can help make that day a little better for you or that day a little safer for you? So we talked a lot about the evidence for harm reduction, about kind of how to prepare for these conversations and some of the specific language for the conversations. And now we're going to transition to talking about the specific content. How do you engage in an actual like harm reduction education session? So I am going to hand that over to my colleague to get started.
Hi, everyone. So we can flip to the next slide. So these are just a couple of things that we're going to talk about today, different types of substances and then different routes of use. So looks like the kind of format got a little bit disrupted, but so some of the things that we're first going to talk about here, we're going to go over the different risks associated with each substance and then some strategies to help reduce harm when it comes to using these substances. So in regard to opioid use, one of the risks is overdose. So overdose can be related to, or factors that contribute to opioid overdose are inconsistent potency of the substance. So getting certain amounts of fentanyl cut into one batch and then a higher or lower amount in the next batch, or getting, real Percocet pills and then the next time getting pressed fentanyl. So just inconsistent potency. Unsafe supply is kind of related to that. Changes in tolerance. So if a patient or person is in the hospital for an extended period of time and not receiving opioids during that time, their tolerance for opioids is going to be very low. And so if there is a return to use whenever they're discharged from the hospital, you want to caution them that they could be at an increased risk for overdose just based on they haven't been using opioids consistently for the past however long they were away from them. The other risk is infection. So we're going to talk a little bit more about that when we talk about the routes of use and how to be safer from that standpoint. So typically, these are the strategies we talk with patients about who use opioids. They're kind of related to the risk of overdose. So First strategy is to carry naloxone or Narcan. We give it to all of our patients here in the hospital, hand it out like candy here. We have a process that there's bedside distribution. So nursing staff in a healthcare setting can provide people with Narcan without provider's order. And that just increase the ability to get people Narcan who could benefit from it. You can also get it from retail pharmacies and local health departments. Strategy number 2 is supportive medication. So I know the last few Kentucky Opens have been a lot about medication for opioid use disorder. So just to mention some of those here, the buprenorphine or Suboxone, methadone, and then naltrexone or the Vivitrol injection. And then strategy 3 are using test doses and fentanyl test strips. So this kind of plays into inconsistent potency, having a change in supplier. So we always recommend start low, go slow. So that's, you want to take a very small amount to make sure that you're going to tolerate it fine. And then you can continue to use more after if you've tolerated the test dose fine. And then fentanyl test strips, I believe, and Alyssa may be able to test this a little bit more, are available at like needle exchange programs, but those are recommended as well. And then we have a note here that potency can be very inconsistent even within the same bag.
Yeah, we tell people about Next Distro. We'll send them to your house for free, depending on what state you live in. I think Voices of Hope are distributing fentanyl test strips as well, and then you can order them on Amazon. They're a little bit pricey, but you can order them. They look like drug tests.
So now we're going to talk about the risks associated with stimulant use. So again, a major risk factor we talk to people about is the risk of opioid overdose, and that can be related to the contaminated supply and mixing of substances. We've had a lot of people come in with accidental overdoses with folks who thought that may have been using methamphetamine or cocaine when actually it contained fentanyl and they had an overdose severe enough that they had to be hospitalized. Another risk associated with stimulant use is stimulant overdose, and that factors contributing to that are using really high doses. And if you've already got existing health conditions, that amplifies that, especially any heart issues. The third risk is risk of psychosis, and factors that can contribute to that are lack of sleep. Again, the contaminated supply. There's a lot of chemicals and fillers used to cut the stimulants with, and that can lead to some unintended consequences like psychosis, and then using for a really long period of time can contribute to psychosis. So what are some strategies we can use to help mitigate those risks? And again, we talk a lot about naloxone, carrying Narcan. Even if someone's not intentionally using opioids, we always like to make sure that they know how to use it, where they can get it. Some of the places that, like Kayla mentioned, that we offer it sometimes here at bedside, we have providers who put in standing orders for naloxone that they can refill up to a year. I know Voices of Hope will sometimes dispense that, as well as syringe exchange programs. Another thing we also talk to them about that puts them at risk for an opioid overdose if they got that contaminated supply is using a loan. So we talk to them about avoiding that if possible, and then if not possible, the Never Use Alone hotline, and then the Canary app that they can download on their phone. Again, a second strategy we talk about is the fentanyl test strips. We encourage folks to test their supply to see if it may contain fentanyl. And that way, if they're informed, they may choose to go ahead and use, but at least they know that they could maybe start low and go slow to see how they tolerate it first. Again, you can get the fentanyl test strips at Next Distro. I think a patient just told me 2 days ago that Voices of Hope were handing those out, I think, at the front desk. And then the health department syringe exchange programs, and then again, Amazon. Strategy 3 we talk about is dose management. So a conversation might look like, are you able to space out your doses to give your body time to rest? We talk to them about also taking good care of their body with just simple things like making sure you're drinking enough, that you're eating enough, that you're getting enough rest to help your body recover in between use. And so we talk about what a stimulant overdose might look like as well. Seizure, heart attack, kidney failure, really high blood pressure, and again, that strain on the heart.
When talking about alcohol use, the risks associated with that are a risk of overdose, drinking too much, heart, liver, and brain damage from prolonged use or use in a very large amount over a shorter period of time, or binge use, and then severe withdrawal syndrome. So with alcohol withdrawal, patients are at risk for seizures. So it's typically recommended that patients enter a monitored setting when they want to stop, when they want to detox or stop using alcohol. So a couple strategies for safer use with alcohol: avoid mixing different types of alcohol, like hard liquor, beer, and then manage consumption. So making sure you're like having a certain number of drinks, every hour, like less, I guess consistency is what managed consumption means. So you want to be spacing out the time in between your drinks, try to substitute some water in between, and then tapering, talking with your patients about what is going to be a reasonable plan for them if they're interested in tapering their use. Perhaps setting a goal of drinking one less beer a day for a week, and then maybe the next week drop it down another one. So again, the little graphic here. So we're gradually reducing the number of drinks, spacing out the length of time in between. Try to include water throughout the day and in between drinks. Mix your drinks, weaker drinks with less alcohol. And then change your preferred alcoholic drink to one that you don't like. So if you prefer wine, try drinking beer. If you like that less, that would decrease your the amount that you use ideally. And then adhering to a weekly reduction schedule with a stop date.
So now we're going to talk about the risks associated with benzodiazepines. For benzodiazepines like Xanax, Valium, Klonopin, the risks often look very similar to those of alcohol. So one of the risks associated with use is that overdose and respiratory depression. And so a strategy that we talk about with folks to decrease that risk is to avoid mixing substances, as that will greatly increase the risk of overdose, especially opioids, because it decreases that drive to breathe. The second risk that we talk about is the risk of severe withdrawal syndrome. So a strategy that we talk to folks about is coming up with a taper plan, and that can be done in different settings, can be done in a hospital setting, it can be done outpatient with a provider. The length of time that is done over will vary just depending on the setting. So sometimes it can be done over a period of days versus a period of many weeks. The third risk that we look at again is the risk of opioid overdose, just again, due to fentanyl contamination and the unsafe supply. We see that a lot, especially with Xanax. We had a gentleman come in actually this week who was at a party, got offered some Xanax, didn't realize that it was actually pressed with fentanyl powder, and he came into the hospital with an opioid overdose. So we talk again about the strategies of carrying naloxone, using fentanyl test strips, and never using alone.
So now we're going to transition to harm reduction when talking about the different routes of using substances. So starting with injection specific risks, the three that we talk about most are bloodborne infections, so Hep C, HIV, the risk of soft tissue and skin infections, and vessel and nerve injury. So as Alyssa previously mentioned, there is a hierarchy to harm reduction. So the gold standard with injection use is we want them using a new sterile clean needle each time, sterile water, a clean new filter, using a new clean or sterile cooker, and then alcohol swab to clean the skin. So opportunities for conversation. When we're talking about the syringe and the needle. So are you reusing your own needles? Are you sharing needles with other people who are using substances? Or are you able to access new fresh needles? If they're reusing needles or sharing needles, are they cleaning them in between? And so the cleaning solutions that we typically talk with them about are bleach, hydrogen peroxide, even soap and water is better than not cleaning them at all. Cleaning the skin, are they doing that in general? Best is alcohol prep, soap and water. They could even take a shower before they use. What are they using for their mix? So when substances come in a powder form, you have to mix them with a liquid to be able to inject them. Are they using sterile water, which is the gold standard? Are they using bottled water? If they're using bottled water, is it a newly opened bottle? Have they drank out of that bottle? Has anybody else been using that bottle for mix as well? If there's multiple people dipping used syringes in the same bottle, that's a really high risk for spreading bloodborne infection. We had a patient, and this kind of relates to the next two a little bit, but Angela shared a story with me about a patient who asked, well, if I drink the bottle of water and my bacteria from my mouth are on that bottle, why is that a problem if they're like my own bacteria? Like he didn't really understand the difference between bacteria being in your blood versus bacteria being in your mouth. Like, so we say mouth bacteria belongs in your mouth, not anywhere else. So drinking a bottle and then using that water is then contaminated with your mouth bacteria. If you're using tap water, do you have well water or city water? Any water outdoors, so standing water, pond, puddle water, creek water. And are you cooking your liquid prior to using? So the picture on the lower left side, you would pass a flame under the cooker or the spoon, whatever you're using, and that helps decrease the number of bacteria in the solution. Are you using a filter with your substances? Is it clean cotton filler? Is it a cigarette filter? Is it from a used cigarette or a new cigarette, or a used cigarette or a new cigarette that hasn't been smoked? We find that patients share that they will lick their needles prior to injection. And sometimes that's for various reasons, to get the last drop of their substances, to get rid of any cotton fibers, or is it just a habit that they're used to doing? So you can ask why, but the important thing is that you find an alternative to that behavior. And then we ask about injection site. Where are they injecting at specifically? We can jump to the next slide to kind of talk more about that. So this is a diagram of kind of safer places to inject. So arms, hands, feet, legs are less risky. There's fewer arteries and nerves, slightly decreased risk for infection, slightly decreased risk of overdose, decreased risk of stroke. The red areas, so head and neck, groin, like your wrists, those have more arteries and nerves. There's an increased risk of infection, increased risk of overdose, and increased risk of stroke with those areas. So if patients are injecting in what we would consider a more risky area, we urge them to utilize other areas that may be less risky. However, we do find that patients who have used substances via injection route for a long time may sometimes have limited access points in the less risky areas, which is why you may find them using in the more risky areas.
Yeah, and we wanted to pop on and kind of add this on too as another helpful tool to kind of add to your toolbox. Sometimes you'll have an hour to just sit with somebody and talk about some of this in detail. Like, so, explain to me kind of what your practice has looked like so far. And you have a very long time. A lot of times, especially in the hospital, we don't have a long time. Sometimes we get 15 minutes and that's all we had, either because they're on their way out the door. They've got a lot of people going in and out. So this is a mnemonic that we use very often to kind of help us make sure we checked all of our boxes, especially when you're first getting started and it's not something that comes as naturally to you. So we keep this in the back of our minds. It'll help you every time just to make sure you don't leave anything out. So we start with arms, the area where, where you're injecting on your body. If you're cleaning the area, covers all those. The reversal agent, which is like whether or not they have Narcan. Can I also give you some? Cool. The materials, everything we just talked about, you're already going to know at this point, probably like what substances they've been using and whether they've been injecting or snorting it or swallowing it, whatever they're doing. And then there's surroundings, then that's the opportunity to talk about never using alone. So it's kind of this super condensed version. So if you're having trouble remembering, I remember you put this on a Post-it for yourself and take it. I used to do that all the time.
So now that we've talked about injection specific risks, we're going to talk about smoking specific risks. So the major risks associated with smoking substances is Hep C transmission and lung damage. So people who may be smoking methamphetamine or crack or anything with a glass pipe, they can get really hot. So that increases the risk of lip mouth burns. And then if people are passing that pipe back and forth, that increases the risk of blood or body fluids being attached to that, which can lead to Hep C transmission. So opportunities we talk to people about that can decrease that risk is, are you able to get your own heat resistant mouthpiece or able to kind of fashion your own? Do you have an alternative to sharing that equipment? We also address the screens that they're using. A lot of people will use like the Brillo pads or the steel wool, and that has a risk of when it gets really hot, either you inhaling it accidentally, those small particles, or also releasing toxic fumes. So we talk to them about heat resistant screens or brass screens as an alternative, and then also cleaning equipment if you do have to share. Now we'll talk about snorting specific risks. Again, a major risk factor is nasal damage and also that Hep C transmission. There are a lot of, the nose in general, the inside is really delicate. It's very sensitive tissue. There's a lot of blood vessels there. So we talk about if you're able to have your own like equipment, straw. We talk about alternatives to like the hard plastic equipment. We talk about like if you're able to get your own, like Post-it notes are a good alternative for that because it's a huge stack. Everyone can get their own. It's single use. We actually have like a banknote down here. A few years back, the UK changed their currency from a paper-like currency to like a harder plastic currency. And when folks were rolling that up and snorting with that, it was actually like lacerating the inside of people's noses. So it's actually coined getting Winstoned now because of that. So again, we'll talk about like the Post-it notes as an alternative. We also talk about taking good care of your nose, like using nasal spray afterwards to get rid of some of that fine powder or any particles that might be left behind that could damage the nasal passages.
And another thing about that was a valuable lesson, I think, to me, was that if you're, I wouldn't have known that if I was not a person who was using drugs at that time. I wouldn't have known about the risk of the change of the formulation of currency. So when you have open communication with people that are using substances, they'll tell you about interesting things to be worried about. And some of that too is about like a bad batch coming out of a different, out of a certain city, or a trend, like a trend that you may not be aware of. So.
One of the other routes of use that we wanted to cover here is called booty bumping, also known as boofing. So I'll share a quick story about that. When I first started in this position, I was fairly naive to harm reduction and harm reduction techniques. And I had a patient come in and I was asking them the various ways that they use their substances. And he mentioned boofing. And I said, excuse me, I don't know what that is. And he explained it to me, and had he not explained it to me, I probably would have been months before I found out. But it was just really great patient educating me on something like that. And now I know to ask my patients about it. But anyway, so the question is this a safer alternative to other routes of use? So the main risk is tearing and rectal damage. So this may be a safer alternative, less risky alternative to folks who prefer injection over snorting or smoking because of the immediate rush. Booty bumping or per rectum administration also gives that kind of rush that patients may feel with injection use, just because that area has a lot of vasculature in it. So opportunities for conversation when you're talking about booty bumping. So does this decrease your risk based on how you're using your substances on a regular basis? Lubrication. So patients may be using syringes like without the needle on top, or like a turkey baster type of device. You want to encourage them to use lubrication so they don't damage tissues. And then talking about rectal care, we put pictures of little vitamins over here. Vitamin E capsules can kind of help promote tissue healing for patients who prefer to do booty bumping with their substances as their route of administration.
All right. And then, you prepared for your conversation, you had the conversation, you had the best of intentions, you gave great information, or you attempted to talk to somebody and they say no. So now what do you do? We'll go to our next slide. It's really common. It's really, really common. I think a lot of people, before they have a relationship with you, they're like, no, because they think what you're going to say is, hi, and I want you to go to treatment today, is usually what they're going to assume about a conversation. They don't realize the framework that you're coming into these conversations with. So if you approach somebody to attempt to have a conversation from a place of harm reduction and they say no, this is what we do. We will usually, every single thing that we talked about today, we leave in writing for our patients. And so that means that some patients they're going to get information they might not be interested in, like they might not use in a certain way. It doesn't matter. We give everything to everybody. We try to use like interesting graphics. We try not to give like paragraph based, sets of information, just like these slides. We talk about hierarchies. We use a lot of graphics. We do all of that. And then interspersed between those, we have various other resources, we just call them like our harm reduction packet. We leave connections with other resources. So sometimes they just don't like you. It's just you. You don't look like you're not a person in recovery, so they don't want to talk to you, or they're not having a good day, or you look too much like their mom. Whatever the reason is, you leave connections to someone else who they may be willing to have that conversation with, a different social worker, a different community resource, a different syringe exchange, a different physician who does the same thing that you do, but leaving the opportunity for that connection to happen with somebody else. We leave the door open for this conversation. Just because they said no today doesn't mean that it won't say no again. So, and this goes for different days of different conversations. Obviously, you don't want to harass somebody too many times, but every once in a while you may revisit it. Like, hey, do you think that this might be something you're willing to talk about now, or that would be interesting to you, or you've had a new complication? Do you think, is there a new way that I can try to help? And that can just be for future hospitalizations. Sometimes we'll see people here who are here for a really short amount of time. And because we leave it on a good note, like, listen, I hear you. Thanks for letting me know your boundary. And the next time they come in, they know that you're a person who respects their boundary. And maybe that's another opportunity. So we always, always, always leave the door open, and then we leave. It is, if someone wants to say no to you, it's not really your job to convince them to say yes. That kind of flies directly in the face of this whole philosophy of harm reduction, right? You present the information you have, you give them the option, and then you leave it alone. And then just kind of in wrap up. So when we say harm reduction saves lives, we mean it. And I think more than that, when we say harm reduction changes lives, we really mean it. So there is evidence to support that it greatly reduces HIV transmission within at-risk populations. When you practice with the philosophy of harm reduction, it increases the access and use of other medical and support services by people in this population. And harm reduction increases engagement in treatment and recovery programs, which can give folks other opportunities to engage with recovery. So I think harm reduction means a lot to us. I'm really enthusiastic about the research that's being done to kind of support this a little bit more in different organizations. And I really, really hope that you leave this conversation feeling kind of inspired and confident, like with more increased confidence to have these conversations. and to change the policy maybe in the place where you work, whether that's just with your attitude or with big stuff like having bedside Narcan, like we do, or fentanyl test strips at your check-in. All right, and then I think we hopefully have covered these learning objectives to understand the philosophies, to articulate the benefits and the challenges of harm reduction, to be able to perform harm reduction interventions. I think in the Q&A, we're going to be absolutely open to having more conversations about how we have these specific conversations, and again, like how you get started on them. But hopefully you're a little more confident in that. And I think we mentioned before, all of us work at UK at the Addiction Consult and Education Service. We're always open to questions and requests for resources. So we'd love to be a resource to you. And if we have questions, I know we'll have a Q&A next week as well, but if you have any immediate questions.
And I don't mean to put my team on the spot. I'm Katrina Nichols with the UK team and also with the Bluegrass Care Navigators Healing Transitions program. And I know that this conversation about harm reduction comes up a whole lot. And knowing that you guys are interdisciplinary with like social work and nurse care navigator there, and I know you guys also have a peer support specialist on your team. Do you guys notice that having different conversations based on, your training, your experience, lived experience, and any tips for our care navigators?
Definitely. Yeah. And we kind of make jokes about this sometimes. It's one of the reasons why we don't round together most often, 9 times out of 10, because different patients will have different preferences. Some folks will only talk to peer support. They do not have any interest in talking to a provider or a social worker or a nurse. Some people, I think you just get a connection with somebody, whatever the vibe was right with that person. So I think it's really interesting. We haven't quite nailed it down on what it is that makes someone more likely for them to talk to. I think it's just chance, but it's one of the just great values of having a team like ours, where we have, our MDs, our APRNs, our social worker, our nurse, and our peer support. So if one of us can't catch them, we usually try to send another one from another area and just see. But definitely big differences. And I think there's differences in how we approach conversations too. If someone has just a super high level of medical complexity, we may want, our nurse navigator to talk to them. This is particularly the case with people who are diabetic. Gosh, it helps so much to have someone with a nursing background to talk to them, especially if they have injection use, because we're talking about from your background as an addiction specializing person, to be able to talk about injection use. And then you have this added, complication of having ready access to needles all the time, and this triggering behavior of having to use needles all the time. So I think that's made a big difference in having nursing specific folks, I think, and as a social worker, I think our superpower is just knowing what's happening in our communities, and having ready resources. So we went in there trying to talk about, this person who has endocarditis. We're trying to help avoid getting it a second time. And, they say, listen, I just really, what would really help me the most right now is if I had food benefits. I just really, could you just help me with my SNAP? We say, absolutely, I can. And is that still a harm reduction conversation? Yeah, it is. Because it's a stabilizing factor in this person's life. And if a person doesn't have their basic needs met, what motivation do they have, to do anything else? So that's a great question. It's been a really cool thing to see.
To piggyback on to that a little bit, I think that's the important part when we go in and have an initial conversation with our patients. We're establishing those mutual goals. So we're able to kind of pinpoint maybe who might be a better fit to approach the person and what their needs are. So.
Oh yeah, sometimes we'll pass a patient, like, they'll be assigned to one of us and we'll say, listen, I just know it's not going to work out with me, but you, why don't you try? And it's kind of an interesting triage. Oh, absolutely. Would a person with multiple relevant backgrounds be a good option? Yeah. And we cross train on this service a lot, and it definitely helps. I was a social worker who worked in domestic violence advocacy before I started working with folks in the infectious disease clinic. I did not know anything about infectious disease at the time, but man, you learn so much so quickly. And it helps because you feel handicapped when you are trying to have a conversation with somebody and you just don't have an understanding of how sick they are or how things work. And now I'm able to say, like, listen, do you understand why I keep asking you if you clean your skin? Well, let me tell you this cool thing I learned. This bacteria that's on your skin, once it gets into your blood, then your blood goes everywhere. And that's why sometimes you inject it in your arm and you got an abscess in your leg. I didn't know that 10 years ago, and now I do, and they're usually surprised too. So multiple backgrounds is great, but if you don't have that background, just don't over specialize. I think if a nurse was the only person who ever talked about nursing stuff and a social worker, like I think Kayla is incredible about talking about social work stuff now. Like I think she's basically an honorary social worker at this point. And I don't think she came into this role with any concept of those things. Don't over specialize, ask your peers what they're good at.